Welcome to Breaking Point, a podcast from CAPC, the Center to Advance Palliative Care. In this limited series podcast, CAPC invites healthcare workers from across the country to share their eye-opening stories from the front lines of the pandemic. Listen as they give us an unfiltered look at their reactions to the demands they've encountered and the coping strategies they've employed as they reach their breaking point. Your host today is Dr. Andrew Esch.
Hi, everyone. I'm Andrew Esch. Thank you for joining us this week on Breaking Point. Today, we are joined by Dr. Allyson Cook Chapman, who is an assistant clinical professor of palliative medicine and critical care medicine at the University of California at San Francisco. Allyson, welcome. Thank you for being here. This is pretty exciting. I know your name, but I have not met you yet in person. So this is going to be nice to chat with you for the next 20 minutes or so and get to know you some. So thank you for being here.
Great. Thanks so much for having me.
Yeah, you bet. So let's just jump right in. You are at the University of California at San Francisco. California, one of the places early on that was hit hard with COVID. Still, COVID and its implications are reverberating through your state. What's it been like working through the pandemic? What's a typical day like for you, if that's even such a thing?
Yeah. I think that we've been really lucky in a lot of ways, but we have seen a lot of COVID and definitely had a lot of ups and downs throughout these different waves. I think that my perspective is interesting in a kind of odd way because I'm an ICU doctor and a palliative care doctor. And I always say I don't cease to be a palliative care doctor when I walk into the ICU, and I don't cease to be an ICU doctor when I'm the attending on the palliative service. So I think that those experiences have been really interconnected and have really sort of changed over time. So in the beginning, from the ICU side, we were had no idea what to expect. We didn't know how to treat this. We didn't know how it was spread. We didn't know anything about it, so there was a lot of, I think, fear just from a personal standpoint, but also just concern, how do we take care of these patients who are so sick and sick in a way that we're not used to, and I think that also affected us from a palliative perspective, in that we usually have a pretty good idea of prognosis. We usually can help families and patients plan ahead, but with this, particularly in the beginning, we just didn't know where we were going with it. And I also think the palliative care team, we all, all of our supportive team, our social workers, our chaplains, everyone was remote just all of a sudden. So having to adapt quickly on the fly to how do we provide palliative care in the really transdisciplinary team approach that is so important to the way we practice was something we really had to do. We just had to sort of figure it out overnight. And so our team, the palliative side, was sort of the team who innovated with let's get a bunch of iPads and let's figure out how to do remote family meetings and how do we, connect families who can't visit their patients. So that sort of started on the palliative side. And then that was our big foot in the door to the ICU, because the ICU team needed to be communicating with all these families whose loved ones were paralyzed and not able to communicate with them at all in the ICU. And so initially, a lot of what we did was just really connect people. So the palliative team became sort of the iPad Zoom team that taught everyone how to do that, how to have a group meeting, how to do all of those things virtually. So that was sort of the first sort of iteration of the pandemic. And then as we sort of figured things out and got, more information, we had more research, UCSF has been, very dedicated to figuring these things out. We have lots of trials going on various treatments and things like that. So I feel like our institution did a really good job of keeping us informed and sort of being on the cutting edge of all that information and then implementing it quickly. So as sort of that stuff happened, I think the next phase was we had a full hospital. We had these ICUs that were full of patients who were having very long-term ICU stays, which is not typical for an ICU. So then the palliative care team's sort of role shifted to this long-term support for the patients and the families and the teams. And I often say to my fellows, when we get a palliative care consult, I'll say, who is our patient? Is our patient the actual patient? Is our patient the family? Is our patient the team? Is our patient the nurses? Who is this consult like primarily for? And I think what was really different about COVID and continues to be true today is that our patient is all of those people. Our teams and our healthcare workers are exhausted. We're all ready for this to be over. There's high levels of burnout at all levels of the system, on the ICU side and the palliative side and the ward side. And then we also have our families who are still not able to come and go freely in the hospital and visit their loved ones. And then we have our patients who, are at the center of all of this. So I think that also became a big thing was, how do we as a palliative care team take care of everyone and take care of ourselves, which was challenging. And I think the team aspect of palliative care is really what saved us and allowed us to do all of that work, because no one person had to do it all. We sort of could carry the load together.
Sorry, I didn't mean to interrupt. Go ahead.
No, go ahead.
No, that concept of team is something we've heard in this podcast series quite a bit. Talk to me a little bit about how, either on the ICU side or the palliative care side, whichever one you want to speak to, but how did you keep your teams together and keep morale up during the different phases of this? Like you mentioned burnout, and we know healthcare workers are really struggling right now. So what were some things that you guys found joy and inspiration from to keep going through all the uncertainty and everything else that was going on?
Yeah, I think on both sides, teamwork is so important to the ICU and it's so important to the palliative care team as well. I think from the palliative side, we just came in with a lot of grace and, recognizing that everyone has a personal life, like outside of our work life. So, a personal story of mine is I was supposed to get married in 2020 and I ended up canceling my wedding and we moved, to a completely virtual format and got creative around that. And so that was a big life event. We had babies that were born in our group. We had people who lost loved ones and couldn't have funerals. And so I think a big thing that our team did was just recognizing that, yes, we were all clinicians, we were all part of the palliative care team, but we were also human and we were going through a bunch of things outside of the hospital, and everyone was just doing their best every day. And so just, assuming that everyone is doing their best and doing what we could to lift each other up. Our team, we round together every morning. So that was, for many, many months, that was hybrid. So we had some people on Zoom because they were remote. We had some people inpatient. But we had this sort of dedicated time where we just check in. And how's everyone doing, what's going on, and sort of allowing space for people to be sad or angry or frustrated or happy, and celebrating those like moments of joy when something was going well, when so many other things felt like they weren't, and just really being dedicated to that team structure. I think just also being flexible. Like if someone was just like, I'm just not 100% today, like, can you lead this family meeting? Can I take a back seat today? Because I'm just really overwhelmed with this. Like just allowing any member of the team to be able to really say that at any time, I think was super valuable and continues to be, a big part of our team, that we check in every day when we're on service. And I think the same of the ICU, we ended up, and I can talk more about this, but the palliative care team ended up doing a proactive sort of screening protocol for our ICU patients who had COVID. And a lot of that came out of, me being in ICU faculty meetings and just really recognizing the distress amongst my colleagues. And, they had 12 intubated, prone, paralyzed patients. And they were like, I can't talk to all these families. I can't do all the support. I can't have all these conversations, and just feeling like they just needed help because we were sort of in over our heads in a lot of ways and just needed some help. So a big thing we did as a palliative care team was just touch base with the ICU teams who had COVID patients. In our hospital, we didn't have one COVID ICU. We had COVID patients scattered across our hospital, across 8 different ICUs. So that was a lot of teams who were dealing with these things. And so we would just check in with those teams, once a week and say, are there any patients that we can help you with? How are you guys doing? Sometimes this was over the phone, sometimes in person, but that sort of harkens back to the who was our patient, and everyone was our patient. So that really gave us the opportunity to check in on those people. But back to just in the ICU, how did we find joy and take care of each other? It was just giving the space. I think having the opportunity to be together, even virtually, for everyone to sort of be their true self and have their true emotion. And, there, also, you have all these, occasionally everyone will test positive and you have to rapidly find coverage and you have to find someone to fill that hole. And, that can be quite stressful, but I think all of my colleagues were just always willing to step up and say, I can cover this day, I can cover this day. As people had to come out because their kid had COVID or, whatever the situation might be. I think we've just really stepped up our game, really seeing ourselves as teams, and that we all are our best when we support each other in that way.
That's always been the secret sauce of palliative care, I think, is that it's more than just medicine, right? It's more than just treating pain and symptoms and things like that. It's the connectivity we have with our teammates, our patients, our families. And that's been hard at times to continue to have that connectivity during the pandemic, but it sounds like you guys are pretty innovative doing it. I wonder, I don't know if nostalgic's the right word because the pandemic's been so awful, but I love the grace that you had for each other. Like so much in the early part of the pandemic, we had grace for our colleagues, we had grace for our patients and families. They had it for us. We were all trying to figure this out as we went along. And now it just seems like we've graduated this phase of the pandemic where people are kind of cranky about wearing masks and whatever else, vaccination. There's all this arguing, and it seems like the tone has changed. Has that changed for you at all in your work? Are you sensing that, or is the camaraderie between, your team and your patients and your family still good? And what do you attribute that to, if so?
I mean, I think that's a complicated question because, I think our teams, on the ICU and the palliative side, I think we are all in the same boat and we are all still trying to row together and, get through this. I think there's a tremendous amount of fatigue just with dealing with the pandemic, even if you don't include all of the other things, and I think the misinformation, just catastrophe that we have, I think has been very frustrating for healthcare workers, myself included. And I think some of that stuff, I feel like my teams are doing okay with all that because we're all still on the same page about, science and things like that. I think it's been hard for a lot of people, myself included, when the other aspects of our life, like family members and things, like that, don't necessarily line up with what we're seeing in the hospital. And I think that's been hard. It's just another layer of fatigue on a group who's already really fatigued. So I think the way that our teams have dealt with that is just, on the ICU side, we are very focused on the science. We are very focused on how we take care of these patients. We're a couple of years in now, we know how to take really good care of these patients. When they come in, we have medications, we have protocols, we have a plan when someone comes in. So we really stick to that. And, we have the, run-ins when it's super challenging in various settings. And I don't want to go too deep into that, but whenever we do have those run-ins, I think we're all still all in it together. So our faculty meetings still serve as that place where we can be ourselves and we can vent if we need to, and we can talk about, how to handle those situations as a group, and back each other up, so that no one feels like they're sort of out on a limb by themselves. And same from the palliative care side. I mean, again, I think just having the team is so core to just getting through all this, like every day, is just knowing it's not you alone.
Yeah, it's been such a journey, right? Like we've had different phases of this, the first wave with all the unknowns, like you described, then Delta, where we were seeing younger patients. And now this wave we're in now, that you just wish that the information was consistent and being delivered to people so they really understood the importance of vaccination and other things, but we can't change everything, I guess. But what would you, advice-wise, give to other ICU docs or palliative care attendings or program leads across the country that maybe work really well at UCSF that you would think they could implement at their hospital or health system?
Yeah, I mean, I think for us, it was really important. I think palliative care teams are often like the helpers. Like we're always looking for like, where can we help? How can we make the situation better? So in the beginning, like we ended up doing an ICU proactive intervention, which worked out really well. But we also reached out to the ED, and we reached out to our floor doctors, our hospitalists, and said, how can we support you guys? Like, what are your needs? And had sort of less formal, but similar communication channels open to them and their leadership, so that we knew how to best allocate our palliative care resources, which were finite. How do we use all of our people best as a team to support our whole hospital? And so I think doing that, engaging multiple stakeholders and sort of saying like, where are we needed the most? I know in a lot of other institutions, New York, for example, I know they had palliative care providers at Columbia embedded in the ED, because that was like the strongest need at the time. And I know other institutions had embedded palliative care in the ICU, or on the wards, or had sort of different intervention models. And so I think just looking at your stakeholders across your institution and like, where can we be the most helpful? What is the need, and how do we support each other best? I think that's what really helped us be successful. And also like, what is the need? So in the very beginning, it was, we needed to teach people how to use Zoom, because that was not something that people were used to. We needed to figure out how to get a family meeting where like 2 people were in Mexico and 3 people were in Texas and some were in California. How do we get everyone on the same screen? And so that was really a role of, shout out to Sarah Peck, one of our social workers, who sort of created a document and laminated it and like put it in all the ICUs about like how to do those things. And then ultimately the institution realized that this was a big problem. Now we have these video navigators who do all of that. But in the beginning, that was just something that we did to help. So I think looking across the institution, and not only who needs help, but like what practical things can you do? And I think that is also really important for team dynamics and how to keep everyone, everyone is tired and everyone is fatigued and everyone is ready for this to be over. But I think thinking of actionable things that you can do within a team to sustain the work. So I think just the flexibility and the grace and the, ability to, without judgment, say, I'm having a really rough day today. Like, I can't do this family meeting, or I need to leave early to pick up my kid because they had an exposure at preschool or whatever. Just the flexibility to do those things, I think, has been really important for sustainability in the ICU and the palliative care side.
Medicine has historically been pretty rigid about stuff like that. Like your training as a surgeon and even mine in internal medicine, it was not kind and gentle. Like it's kind of a harsh training that we go through. To see this morph into giving each other some grace and giving each other some, room to be human and worry about things at home. And like you described, that's been one silver lining in this for me. I just feel like the work environments have gotten much more understanding to the outside events that can impact it.
I would definitely agree. I mean, I think the intolerance of coming to work sick has been, I think, an important part of that. Now we have screening protocols that if you don't pass the screener, like you have to get tested, you have to stay home. There's a policy, in my surgical residency, I don't think in 5 years I took a sick day. I was just worked through it, which is not what we should have done. Wasn't the best thing for our patients or ourselves or our colleagues, because then everyone gets sick. But I think that has sort of offered space for that, like where before it wasn't. Now, if you have a headache or you have a runny nose or you have a fever, like you don't just fight through it, like you stay home.
Right.
And if you show up and you're coughing, like your colleagues are going to send you home, and be probably displeased with you because now they might have been exposed. So I think that also has set the stage for flexibility in other ways, and an acknowledgement that we're not just our physical health, we're our mental health too. And, I know palliative care has always been much more in tune to those human aspects of people. But I think, and I hope that we're seeing it in other aspects of medicine. Though it's still not perfect, but I think it's definitely, we've taken some steps, and I agree, it's a silver lining.
Yeah, I think so. What else do we need to know about you? Like what's next for you? What do you have to look forward to in the next 3 months, 6 months, a year, however far out you want to go?
One of my major passions and like a driver for me to do the work that I do is that I think all of our patients deserve to be cared for like human beings. And I think palliative care is what does that. We attend to the whole person. And I think in order to do that, we really need to train physicians and sort of change the way we think about training in a lot of ways to equip physicians and other clinicians to do that. So a big part of my work is primary palliative care education for non-palliative care specialists. I think every surgeon should be very skilled in serious illness communication. I think every medicine doctor should know how to do a good spiritual screen and know what the resources are for that. So that's something that I work on a lot in the surgery department and in the ICU. And so that's a big part of the work I do going forward. And as I mentioned before, like life continues, even though we're in a pandemic. We are in the hospital and we are also out of the hospital. So I think the biggest thing in the next several months for me is I'm gonna have a baby. And so,
all right, congratulations.
Thank you. So, that's another layer to everything is, you don't always know what's going on in people's lives. And so that's why grace is so important, and flexibility. I had to, my ICU colleagues have covered me when I needed to go have appointments and things like that. And sort of it's just become more like no questions asked, which I really appreciate. So those are sort of the big things coming up for me, continuing the work. I do a lot of patient care, and that's the joy of my career. And so continuing to do that, and also teach all those around me so that we can take better care of our patients.
Right. Well, yeah, that's the goal, right? Grace and flexibility. I love it. I'm going to remember that from this 20 minutes we spent together. Allyson, thanks so much for being with us on Breaking Point. I really, really enjoyed this, and I wish you luck. You have a lot to be excited about in the future.
Thank you so much. It's really nice to meet you.
Thank you for listening today. For debriefings, the Emotional PPE Toolkit, and more, visit capc.org/COVID-19.